Okay, hi. Today I'll be talking about carpal tunnel syndrome. Carpal tunnel syndrome is a compressive neuropathy of the median nerve at the level of the wrist joint. The diagnosis is usually made clinically. There are multiple risk factors that can contribute to carpal tunnel syndrome, which includes obesity, diabetes mellitus, pregnancy, hypothyroidism, rheumatoid arthritis, chronic renal failure, and also alcoholism. For the anatomy, the border of the carpal tunnel, the lateral border is formed by um, scaphoid tubercle and also trapezium. The medial border is formed by hook of Hammett and also pisiform. The floor of the carpal tunnel is formed by proximal carpal row, and the roof is formed by transverse carpal ligament. The contents of the carpal tunnel includes 4 tendons of flexor digitorum superficialis, 4 tendons of flexor digitorum profundus, median nerve, and also the flexor palmaris longus tendon, which is the most lateral structure. The carpal tunnel is narrowest at the level of hook of Hammett. At the level of the wrist, the median nerve give out 3 branches, which is the digitocutaneous branch, which give sensory innervation at the lateral 3.5 digits. The recurrent branch, which supply the tena muscle component, and also palmar cutaneous branch, which gives sensory innervation at the lateral palm. But the palmar cutaneous branch does not go through the carpal tunnel. Usually, patients with carpal tunnel will be presented with pain, numbness, and tingling sensation at the lateral 3.5 digits. They also can present with clumsiness and also pain and numbness, usually that will awaken them at night. From the examination, on inspection there might be tena muscle atrophy. On palpation there might be tenderness over the carpal tunnel, and there are 3 special tests that we can do to test for carpal tunnel. The first one is Fallon test. The test is performed by asking patient to do wrist volar flexion against gravity for about 60 seconds, and then the test is positive when there's pain and numbness reproduced. The second test is Tinel test. It is performed by tapping over the median nerve at the carpal tunnel, and then the test is positive and there is paresthesia over the lateral 3.5 digits. The third test is Durkan's test, or carpal tunnel compression test. It is performed by pressing the thumb over the carpal tunnel and holding the pressure for about 30 seconds. The test is positive when there's onset of pain and paresthesia at the median of distribution. Imaging is not needed for to diagnose carpal tunnel syndrome. The differential diagnosis for carpal tunnel syndrome includes AIN compressive neuropathy, pronator syndrome, ulnar tunnel syndrome, and also cervical radiculopathy. We can also do conduction of studies to not to confirm the diagnosis, but to objectively evidence the compressive neuropathy. We can do conduction of velocity or electromyography. For the treatment of the carpal tunnel syndrome, it can be divided into operative and non-operative. For non-operative, it is the mainstay of the treatment. We can give patient NSAIDs, for example, Celebrex, to reduce the pain and inflammation, and then we can also refer patient to occupational therapy for night splints. Usually it is useful for patients who have nocturnal symptoms. We can also refer patient to physiotherapy for pain modalities, for example, ultrasound or warm compression. Besides that, we can taught patient few exercises. We can ask them to do squeeze ball for hand and grip strengthening. We can also teach them wrist flexion and extension stretching, median nerve glide, and also tendon glide. Activity modification is also important. We should advise patient to avoid any aggravating activities. for the operative management of the carpal tunnel, we can do carpal tunnel release. It can be done endoscopic or open. Endoscopic carpal tunnel release can accelerate rehabilitation. For open carpal tunnel release, it has a few complications. The first one is it can has incomplete release, and it can cause progressive tendon muscle atrophy due to injury to the recurrent branch of the median nerve, and also lumbrical muscle weakness due to the injury of due to neuropathia of the palmar digital nerve. The open carpal tunnel release has a good outcome. Usually the grip strength will return in 6 weeks, and then the sensation, usually the grip strength return in 6 weeks, and the pinch strength is written in 6 weeks. The grip strength usually return 100% pre-operative after 12 weeks. Thank you.